Hello, and welcome to the Gastrointestinal Lecture Series. My name is Katie Lee Huang, and I'll be helping you review the GI system. There's quite a bit of material here to discuss, so let's get started and jump right in with a review of embryology to give us the background we need before moving into the anatomy, physiology, and pathology of the GI tract. Let's begin with embryology and look at how the GI tract forms. The primitive gut can be divided into the foregut, the midgut, and the hindgut, with each segment of these giving rise to specific gut and gut-related structures later in development. Luckily, these structures correlate well with the position of the embryonic structures. First, the foregut contains the structures from the pharynx to the duodenum, which you can see here in orange. Next, the midgut is from the duodenum to the transverse colon, which you can see here in purple. And finally, what is the hindgut? Well, the hindgut is from the last third of the transverse colon to the rectum. The blood vessels that supply these structures are the same throughout development. At week 6, the midgut undergoes rapid growth and herniates through the umbilical ring, since the fetus cannot yet accommodate the size of the midgut. At week 10, the abdominal cavity enlarges and the midgut is able to return, but when it does this, it rotates 270 degrees around the superior mesenteric artery. The GI organs are now in their adult positions, which you can see here on the right. Okay, let's do a quick flash quiz now to cement our learning. The midgut of a newborn with severe abdominal distension is found to be malrotated around the blank artery. Which artery is this? That's right, it's the superior mesenteric artery. Remember, at 10 weeks, the midgut, which contains the duodenum to transverse colon, rotates around the SMA and returns to the abdominal cavity. Interesting pathologies can result when there are developmental defects. There are a number of developmental defects of the anterior abdominal wall. What are some examples? Well, let's go over some examples of anterior abdominal wall defects in this table. First, rostral fold closure results in sternal defects. Second, incomplete lateral fold closure can result in omphalocele and gastroschisis, which we will discuss more in a moment. Lastly, inappropriate caudal fold closure results in bladder exstrophy with part of the bladder outside the abdominal wall. Let's now talk about gastroschisis and omphalocele. So what is gastroschisis? Gastroschisis occurs when the abdominal contents extrude through abdominal folds and are not covered by the peritoneum. In contrast, omphalocele is when the abdominal content herniates into the umbilical cord, as you can see in this image. As you can see here, the abdominal contents are covered by peritoneum. A good way to remember this is that omphalocele is sealed by the peritoneum. Let's go over a few more important developmental defects. Duodenal atresia is where the bowel fails to recanalize. Do you remember which chromosomal abnormality it is associated with? That's right, it's associated with trisomy 21. On abdominal radiograph, you can see a double bubble sign, as you can see here on the right, which is due to dilation of the stomach and proximal duodenum. Here you can see where the normal bubble would be from the stomach, but here is the second bubble. Jejunal, ileal, or colonic atresia is due to a vascular accident during development, leading to ischemia and narrowing or obliteration of the affected area. This results in an apple peel appearance of the bowel, as it spirals around its vascular stalk at the gross level, and hence it's called an apple peel atresia. Next, let's go over tracheoesophageal fistula. A tracheoesophageal fistula is exactly as it sounds like, an abnormal connection between the esophagus and the trachea, and most of the time this is associated with esophageal atresia. There are many different permutations. First, there's the most common subtype. This is where a blind upper esophagus and a lower esophagus that's connected to the trachea occurs, which you can see here. This is called type C. You can remember this since it is the most common, C for common. There is also type A, and this is where there's a proximal and distal esophageal bud, but no middle part. There can also be, as you may have guessed, type B. This is where the proximal esophagus connects to the trachea. Type D is where the proximal and distal esophagus connect to the trachea. Finally, the last type, type H, kind of looks like the letter H. And this is where the proximal and distal esophagus all meet together. This makes it pretty easy to remember. The clinical presentation of tracheoesophageal fistula is quite striking, and once diagnosed, prompt surgery is required. Tracheoesophageal fistula can cause cyanosis, an air bubble on X-ray of the chest, and pneumonitis due to the upper esophagus being connected to the trachea. Other features also include choking and vomiting with feeding, and failure to pass an NG tube into the stomach. Finally, tracheoesophageal fistula can cause polyhydramnios, which is excess amniotic fluid in the amniotic sac due to the infant's inability to drink. Okay, let's next talk about congenital pyloric stenosis. Congenital pyloric stenosis occurs when there's a narrowing of the opening from the stomach to the intestine as a result of hypertrophy of the pylorus. This occurs at the region of the stomach connecting to the duodenum, which you could see here on the image, and this causes an obstruction. On physical exam, the hypertrophic pylorus is often palpable, and this is commonly called an olive mass. This also presents in the first 2 weeks of life. Since food can't pass into the intestine and the stomach is trying to squeeze the food into there, this force causes projectile vomiting. However, since it never makes it to the intestine, it's non-bilious. Here we can see an ultrasound of a 5-week-old boy with non-bilious projectile vomiting, and here's the pyloric stenosis. This is much more common in males. Okay, let's continue along the GI system. The pancreas is derived from the foregut, and hence it is endodermal in origin. Pancreatic development begins with the formation of the ventral and dorsal buds, which you can see here. The ventral bud becomes the head and the uncinate process, whereas the dorsal bud becomes everything else, including the body, the tail, isthmus, and accessory pancreatic duct. The spleen, on the other hand, is not derived from the foregut, but is derived from the dorsal mesentery. It is, however, supplied by an artery of the foregut, the celiac. When the ventral pancreatic bud encircles the second part of the duodenum, this forms what is called an annular pancreas, and this encircling can result in duodenal narrowing, which you can see here. Finally, pancreas divisum occurs when the ventral and dorsal buds fail to fuse, leading to exactly what it sounds like, a divided pancreas. Congrats! You've now made it through the embryology section. Let's now do a review question to solidify the concepts you have just learned. A 22-year-old woman presents to the hospital in labor. She has missed her last couple of months of prenatal care visits. After several hours of labor, an 8-pound, 3-ounce girl is born. Shortly after birth, the newborn girl is found to be unable to swallow. On attempts at feeding, she coughs, chokes, and vomits. An X-ray image reveals a tracheoesophageal fistula, and the newborn is promptly scheduled for a corrective surgical procedure. If this girl were symptomatic at birth, which of the following may have been present during the mother's pregnancy with this child? Is it A, hematosalpinx, B, intracranial calcification, C, microcephaly, D, oligohydramnios, or E, polyhydramnios? That's right. The correct answer is E, polyhydramnios. Let's go over this in more detail. Remember, tracheoesophageal fistula is associated with esophageal atresia 95% of the time. Due to the fetus's inability to swallow amniotic fluid, polyhydramnios, or an excess of amniotic fluid, occurs. Other gastrointestinal causes of polyhydramnios that influence the fetus's ability to swallow amniotic fluid can include facial cleft, duodenal atresia, and annular pancreas causing an obstruction. Congratulations! You've now finished the GI embryology section.